Lydianne's just outlined. As many of you will be aware, GLIMF, or fluidopathies, has been coined as a term linking these several diseases, as Meryl mentioned earlier, which have related components to this brain waste clearance mechanism. These come from several origins, including mechanical forces, abnormal blood-brain barrier, but also various other factors, including inflammation, sleep abnormality. But ultimately, all of them contribute to impaired interstitial fluid dynamics and accumulation of waste proteins. For this talk, I'm not going to try to cover all possible neurodegenerative conditions because we need an awful lot longer, and I probably wouldn't be qualified for that kind of talk. Instead, what we'll be focusing on is just a brief mention of idiopathic normal pressure hydrocephalus, which has been mentioned is one of the primary techniques, primary conditions where we can use intrathecal injection. I'll be mentioning small vessel disease and aging, which is very much a component of that. And then moving on to Alzheimer's disease and multiple sclerosis. Now, preparing this, I had a quick look at literature. It's clearly on the rise, so it's a popular area. And it's covering quite a broad area, range of conditions as well now, as mentioned. And this is also a good chance just to mention the elephant in the room, but we'll come back to him a bit later. So normal pressure hydrocephalus, as most of you will be aware, is a neurodegenerative condition which is characterized by CSF disturbance and associated with gait impairment, cognitive problems, and urinary incontinence. Typically, treatment depends on shunt surgery to divert the CSF in eligible patients, and they're selected for that partly based on what's called a TAP test, where there's a lumbar puncture and they remove some of the CSF and then reassess symptoms to see if it's improved or not. As has been mentioned, Ringstad's group has done an awful lot of important work on this, looking at the distribution of intrathecal injection contrast agent in normal pressure hydrocephalus relative to reference images, often where participants have other indications that indicate you might have these conditions and therefore justifying intrathecal injection. As has also been mentioned, we see differences in the profile, so how tracer uptakes in these cases with delayed uptake in the normal pressure hydrocephalus relative to a reference, and also between different areas in the CSF. So the profile in the reference images on the left and the normal pressure hydrocephalus on the right is quite different. And indeed, if we look at how that evolves over time, there's also quite significant differences in the concentration of the gadolinium in blood, which varies depending on the exact condition. So your reference has a relatively early uptake, whereas INPH in the yellow is a bit later. As we've already heard, tracer enrichment differs between patients with good and poor sleep quality, with sleep impairment being associated with impaired CSF tracer enrichment in several brain areas across your brain, as you can see in your diagram, with higher areas in the red. And also in patients with indications for lumbar puncture, it's not just done up north. You also find lower clearance through putative meningeal lymphatic and perineural pathways in older patients, with clearance through peri-olfactory, around the nasal cavity, which is higher in patients, again, with better sleep quality, but also better cognition, which is one of the kind of broader links to health. Also, several of the diffusion metrics, which Lydian's mentioned, come into this. ALPS indices tend to be higher in controls versus pseudo INPH cases in normal pressure hydrocephalus, although, as has been mentioned, that should be interpreted with some caution in light of Professor Teoka's recent work, recommendations on it. Whereas it's also been confirmed with correlation between ALPS index and motor function using a timed up and go, how quickly a patient takes to get up and walk, and correlation between the mean ALPS index and MSE, which is a short cognitive test. Also in the diffusion space, using IVIM, Bagato et al. Found patients who responded to a TAP test tended to have lower diffusion in non-responders, and post-TAP test responders had reduced pseudo-diffusion and higher perfusion fraction in the non-responders. Similarly, in the corona radiata, the pseudo-diffusion was reduced. Now, that's quite a slightly more extreme or rare condition. Small vessel disease, however, is very common. It causes around a quarter of strokes, 40% of dementias, but it's also very common in health aging. So around a third of patients over 65 will have some signs of small vessel disease, and that only increases as you get older. Typically, it's diagnosed in MRI, and there's several features associated with that, which are codified in the STRIVE criteria, including a recent update led by Marco During. And particular interest for us is, of course, the perivascular spaces, which are a major sign of small vessel disease. It's not just structural imaging, however. We know that blood-brain barrier permeability tends to be higher. Inflowing arterial pulsatility tends to be higher in the large vessels, and also cerebrovascular reactivity, your vessel reactivity within the brain, tends to be reduced. So given those factors, there's quite obvious links or potential links to your brain waste clearance. In some recent work in Edinburgh, we assessed this using intravenous contrast injection, identifying several areas which were rated both visually and semi-quantitatively, with a visual score ranging from no enhancement through to strong increase in signal intensity. And from that, we found that there were associations with the visible perivascular space scores across all areas, and the nearest association with the total SVD score, so the overall burden of SVD brain in these patients, so it was a relatively small sample. Similarly, Zhang et al. Also used intravenous contrast agent, finding most of the SVD patients showed cortical periarterial enhancement, as well as enhancement of enlarged perivascular spaces in the basal ganglia, but that was not present in the controls. Meanwhile, at 24 hours, which is a much longer time than we managed to do, you had lower clearance rates at 24 hours and higher change in the signal intensity ratio relative to a control region in the putamen cerebral cortex and the meningeal lymphatic vessels, which run alongside the superior sagittal sinus. Now, we've already heard about the PVS burden. Typically, that's assessed in T2 or occasionally T1 weighted images. Ramirez, in a study using cerebrovascular disease patients based in Canada, found participants with more perivascular spaces tended to spend more time in beds, they slept for longer. But despite that, in the basal ganglia, PVS were still associated with greater likelihood of reporting daytime dysfunction. So even with additional sleep, you're still not getting any better for it. On a similar note, Wang reported white matter and basal ganglia PVS were associated with other SVD markers, including vascular risk factors. Now, interestingly, it's not just about looking at your causes of this, it's also about what we can do about it. In this work by Kern et al., you had a secondary analysis of an intensive blood pressure lowering study. And they found that perivascular space volume fraction was associated with older age, concurrent cerebrovascular disease, worse white matter hyperintensity burden, which is one of the other major indicators of small vessel disease, and brain atrophy. But importantly, longitudinally, your patients on intensive blood pressure lowering showed decreases in perivascular space volume relative to standard treatment, suggesting there may be ways of modulating your visibility of perivascular spaces using existing treatments. Similarly, given the relative accessibility, you've been able to apply several diffusion metrics. So Lee et al. Found it increased basal ganglia perivascular space volume, increased free water fraction, and decreased DTI ALPS are all related to SVD progression on MRI and also cognitive decline over time. So you are all pointing in similar directions in terms of the effect. Whereas Zhang et al. Also found that modified ALP index without having SWE to actually assess the angulation of your vessels exiting from the periventricular area, associated with more white matter hyperintensities, basal ganglia PVS, and also number of lacunes and microbleeds, so more of those SVD indicators. Meanwhile, Chan et al. Found that patients with lower DTI ALPS index tended to have greater risk of SVD presence and higher total SVD burden. Although, interestingly here, it's only in the first quartile that you see a particularly large effect, so all of the others are within the margin of error, perhaps suggesting it needs to be quite advanced in order to provoke an effect, at least for your DTI ALPS metric. Wang et al. Looked at a healthier community-dwelling elderly population and showed that higher diffusion DTI-ALPS was associated with better cognitive function cross-sectionally, and you were also less likely to suffer cognitive decline, which is one of the major outcomes that patients care about in terms of aging and kind of diagnoses we'll be getting on to later. And older patients also had lower DTI-ALPS, suggesting it is a progressive change. Meanwhile, Akenzie found associations between different inflammatory markers in a blood panel with basal ganglia PVS, again in a community-dwelling elderly population with no history of stroke and dementia, so it's not end stage in that respect. Of course, as has also been mentioned, sleep's a major factor in this, and in this interesting preprint from Lewandowski showed that CSF movement across the subarachnoid space was reduced after sleep deprivation relative to normal sleep in young adults, but did not differ between rested young and old adults. Meanwhile, the cortical CBF and the transendothelial exchange using an ASL metric were unchanged after sleep deprivation, but lower in older adults in the younger population. Now, moving on to Alzheimer's, which I'm sure most of you will be aware of already. It's the most common cause of dementia associated with memory loss and cognitive impairment. It's a progressive neurological condition of a continuum which ranges from mild cognitive impairment, or MCI, through to severe dementia, and it's particularly associated with buildup of beta amyloid and tau plaques, which have been implicated in AD, as Meryl mentioned earlier, and may be exacerbated by this impaired brain waste clearance mechanisms. Looking at structural metrics and PVS burden, community-dwelling elderly showed an increase in all-cause dementia, AD and vascular Alzheimer's over a follow-up period of 8 years. The dementia hazard, interestingly, increased with PVS burden, doubling with from grade 1 to grade 2 PVS, so even small increases in your PVS burden can have an impact at that level, with similar trends for both Alzheimer's and vascular dementia in isolation, though vascular dementia didn't reach conventional statistical significance. The other interesting work I wanted to flag, which wasn't mentioned in Lydian's talk, is the cerebrospinal fluid fraction, which derives from myelin water fraction maps. So for this, 3D fast T2 with multiple echoes is acquired, and you separate out your water fraction by isolating your CSF component. And in that work, you found it tended to increase with age, was greater in MCI AD in controls, and was associated with AB deposition, which again is one of the big predictors for Alzheimer's. We've already heard a bit about Han et al. Results, where you showed that bold CSF coupling decreased with worse AD pathology, worse disease severity in older patients, and also with higher cortical A beta levels and poorer cognition at 2-year outcome. And you can also look at this with more conventional bold imaging. So in work from Ulu, you found that higher bold signal variability in AD populations versus controls, mostly due to cardiovascular brain pulsations, going back to the earlier question for Meryl. And interestingly, that applied where it was 1.5T images at the top, the 3T images in the middle, or the MREG, or MR encephalography method applied by Visa Kavinimi, with all of them showing changes around basal ganglia and periventricular areas, with the resultant abnormal cerebral perfusion and CSF convection potentially contributing to the impaired lymphatic clearance we see in Alzheimer's disease. In similar work using MREG this time, Rajan et al. Reported spatiotemporal differences in the propagation speed and arrival latency in our Alzheimer's disease patients versus controls. So there are differences in how your pulse is getting through your brain, perhaps related to getting tangled up in other things or just poorer driving mechanisms in the first place. And again, there's been several diffusion studies using free water imaging, for example. Sashi et al. Found that higher free water in Alzheimer's disease and other neurodegenerative conditions and in cognitively unimpaired participants. and in more atrophic AD patients versus the cognitively unimpaired. Both total PVS count, white matter PVS volume were higher, white matter mean kurtosis and mean ALPS index were lower. Although we highlight it's necessary to account for disease stage, which is one of the other factors to consider in developing these studies and what is the most suitable metric to apply. Similarly, several other papers have used ALPS, finding it's worse in Alzheimer's and controls, correlates with PET measures of amyloid burden, and also with different measures of higher PVS, white matter volume, lower ALPS index in AD versus control, as well as CSF markers for inflammation, FDG uptake using PET, and poorer cognition. Finally, looking at multiple sclerosis, as most of you will be aware, it's an autoimmune disorder which affects the central nervous system, causing demyelination, but also neurological symptoms. It's thought to be driven by inflammation and microglial activation, which are key factors in the development. While many MS patients have recurring bouts of symptoms, relapse and remission or relapsing remitting MS, and that may evolve into a secondary progressive condition where it's a downward trajectory, whereas a small proportion of patients also experience continuous disease progression known as primary progressive MS. Looking at intravenous contrast agent, Hildesheims found that patients with electromeningeal contrast enhancement and vessel wall enhancement tended to be older. Around a quarter of patients had enhancement of electromeningeal areas and the vessel wall with around 50% showing it in the dura mater and falx cerebri. However, the enhancement didn't associate with clinical or imaging markers of disease severity. Meanwhile, Gabra reported dural lymphatic enhancement in most patients 2 to 3 minutes after contrast administration, with brain parenchymal fraction correlating with the area under the curve, peak enhancement and the wash-in slope, though there were few correlations with the disease parameters, although a trend correlation between age and area under the curve. Looking at PVS burden, which is also applicable in MS, you found more PVS in multiple sclerosis patients than controls, so the size didn't differ. Louis et al. Reported patients with MS tended to have higher PVS burden in controls, so it's correlated with age and hypertension, but not disability using a EDSS score. Whereas Colby found that late relapsing remitting versus early relapsing remitting MS had a greater average number of basal ganglia PVS, but progress didn't differ, with some of the results suggesting there's a threshold effect where after 4 years it probably doesn't deteriorate any further. Looking at diffusion metrics, again, there's been several papers in that using DTI-ALPS in MS versus control. MS patients tended to have worse disability and longer disease duration with lower ALPS index. And Bayumi reported worse disability in patients with lower mean ALPS, which correlated with disease duration and a disability scale, with both ALPS and lesion load predicting lower disability. Again, with diffusion metrics, higher choroid plexus and lower DTI-ALPS were associated with relapsing remitting MS relative to controls, with several differences that were region-specific. Choroid plexus volume and DTI-ALPS also correlated with the disability score, and longitudinally, choroid plexus volume increased, and patients with greater increase in ALPS tended to have smaller changes in disability over that period. Lower ALPS index was also correlated in secondary progressive MS versus relapsing remitting, suggesting it's a more serious condition, while patients with secondary progressive MS tended to have longer disease duration and higher disability in the relapsing remitting cohort. Finally, we go back to our elephant. So there's a temptation just to focus on one area or one particular measure, and that's actually very challenging to do, as we've heard, when you're studying the lymphatic system. There's lots of different areas to consider, and therefore you need multiple techniques in order to probe them. And the next steps, we've heard about technique development, developing consensus, and there's several initiatives ongoing for that. Hopefully give people who want to apply it in patients a clearer steer on what the priority should be, contemporaneous assessment, and developing novel therapeutic targets. With that, I'll finish, and if you have any questions, I'm happy to try to answer them. Thank you.
Thank you very much. We have time for 2 short questions.
If not, I can ask if you could elaborate a bit more. You mentioned reactivity pulsatility and, arterial stiffness. How can that sort of relate to these sort of lymphatic clearance mechanisms?
Yep, certainly. So as we've heard, there's various drivers for a lymphatic system or brain waste clearance. Several of those come through your vascular system. So in terms of arterial pulsatility, if the flow going in is rougher and that passes on to your small vessels, it can damage those small vessels with quite fine vasculature. And that can lead to further damage, deterioration, vessel wall damage, and then you've got more influx of waste that has to be cleared out, so you create a backlog. It also passes on through cerebrovascular activity, often measured with BOLD or ASL metrics in response to gas stimulus. And in those patients, if the vessels themselves aren't moving as much, then that's probably less of a driver for your surrounding area. Obviously, you've still got the overall cardiac fluctuation going on, but it maybe not be passed on as effectively through tissue if it's becoming stiffer and less flexible.